Let's look at some of the expectations and realities of working in healthcare settings and what that means for you as a clinical engineer. So let's explore how care is organized within practice environments and where biomedical equipment technicians and clinical engineers fit into those structures. Also, privacy laws and how they affect not only the clinical work but also the technologies you support, and professional and ethical issues you may face every day, from balancing safety and compliance to weighing cost and efficiency. As BMETs and clinical engineers, your job isn't just about keeping machines running, it's about working inside a system of people, policies, and values. We're going to go ahead and see how those socio-technical factors shape the way technology is used, maintained, and most importantly, trusted in healthcare. By the end of this lecture, you should be able to define medical error and patient safety and how technology can help or harm. Discuss errors at both the individual level, slips, mistakes, and the system level, workflow and integration. Compare how social and technical factors interact to create resistance to change. Identify challenges of adapting work processes to new technologies. Evaluate the risk of enforcing technology into existing practices. Assess the impact of socio-technical on quality, efficiency, and safety. And finally, the HTM connection. These skills will help BMETs and clinical engineers align technology with real-world workflows to support safe, effective patient care. Patient safety is one of the highest priorities in healthcare. To help reduce preventable harm, the Joint Commission established the National Patient Safety Goals. Some key focus areas were preventing infections caused by antibiotic resistant microorganisms through strict sterilization and equipment safety, reducing catheter related bloodstream infections with sterile technique and proper maintenance, preventing surgical site infections by ensuring sterile equipment, correct prep, and reliable surgical technologies. Now, here is where the HTM connection comes into play. BMETs and clinical engineers directly support these goals by 1. Keeping sterilization equipment reliable, 2. Maintaining infusion pumps, monitors, and catheter related devices, 3. Ensuring surgical technologies from anesthesia machines to electrical surgical units function safely, and 4. Working with infection control teams to minimize device related risk. Every calibration, repair, and preventive maintenance task isn't just technical, it's a patient safety action. HTM professionals play a direct role in achieving these national goals. One small but powerful step in improving patient safety was the creation of the Do Not Use list of medical abbreviations. And here's a timeline. In 2001, the Joint Commission issued a warning that confusing abbreviations were causing patient harm. In 2002, a national patient safety goal required accredited organizations to create their own Do Not Use list. By 2004, the Joint Commission published an official list as part of accreditation, and in 2010, it was integrated into information management standards, embedding abbreviation safety into policy. And why this matters. Abbreviations like the capital letter U for units, which can be mistaken as a zero, or the capital Q, capital D for taken once daily, can be mistaken for QID, which is four times daily. These have caused serious errors in the past. The standardized do not use list eliminates that risk. What does this mean for HTM professionals? So for HTM professionals, this connects directly to your work, ensuring labels, device screens, and printouts are standardized terminology, verifying EHR and device integrations avoid unsafe shorthand, supporting training and compliance so device interfaces meet Joint Commission standards, and standardization reduces ambiguity. Just as clinicians must avoid dangerous abbreviations, HTM professionals must make sure that technology systems, interfaces, and documentation reinforce these same patient safety goals. Hospital acquired infections, or HAIs, can be dangerous, even fatal. That's why infection control is one of the most critical patient safety initiatives in healthcare. Common methods in inpatient settings include strict hand hygiene, from washing to waterless rubs, immunizing staff to prevent the spread of disease, appropriate antibiotic use to avoid resistance, isolation protocols for infectious patients, ongoing training and competencies checks to keep staff current, and safer delivery systems like single-use IV flush vials to prevent contamination. Here's where the HCM connection comes into play. Infection control isn't just about clinicians, it's also about the technology that supports them. Sterilization equipment like autoclaves, washers, disinfectors must work flawlessly. Ventilation and negative pressure rooms depend on proper engineering. Infusion and delivery systems must stay reliable to reduce risk, and water systems like dialysis units or heater coolers need constant monitoring to prevent bacterial growth. Infection control is not only a clinical issue, it's a socio-technical challenge. Every time BMETs and clinical engineers keep sterilization devices reliable, pumps accurate, and air and water systems safe, they're directly reducing hospital-acquired infections and protecting patients. Even with highly skilled surgical teams, errors can happen in the operating room. Some of the most serious are wrong site, wrong procedure, or even wrong patient surgeries. And here's the background. In 2003, the Joint Commission approved the Universal Protocol to prevent these errors. By 2004, it became a requirement for all accredited hospitals, ambulatory centers, and office-based surgical facilities. The Universal Protocol has three key components: patient and site verification, which means confirming the correct patient, procedure, and site before starting; site marking, which means clearly marking the surgical site, to avoid confusion; and three, a pre-procedure timeout. The team pauses to review critical safety details before making the first cut. What does this mean for HCM professionals, and where do you come in? Well, this is it. You ensure that surgical equipment and imaging devices are calibrated and reliable. You make sure that device interfaces and labeling align with safety standards. You support checklists and systems prompts that reinforce the timeout process, and maintain redundancy and backup systems such as power, monitors, alarms, so technology never adds risk. The Universal Protocol is a human plus technology safety system. Clinicians perform the checks, but BMETs and clinical engineers make sure the tools behind those checks are safe, reliable, and repeatable. Patient safety isn't just pushed by clinicians, hospitals, or regulators. It's also promoted by independent organizations. One example is the Leapfrog Group. It's a voluntary program launched by large employers and healthcare purchasers. Their goal? To push for higher quality and safety standards in the care delivered to their employees and members. Leapfrog evaluates hospitals through tools like the Leapfrog Hospital Survey, which tracks safety practices such as infection prevention, medication safety, and surgical care standards. Here's where the HTM connection comes into play. Hospitals and programs like Leapfrog depend on accurate reporting of device-related safety practices, things like alarm management, sterilization, and infusion pump safety. These surveys also check how well technology is integrated into workflows and whether hospitals meet benchmarks for safe, effective use of devices. That means every calibration, every maintenance check, and every bit of documentation you complete as an HTM professional contributes directly to how a hospital scores and how safe it truly is. Initiatives from groups like Leapfrog show that safety is both a clinical and technical responsibility. HTM teams are essential in helping hospitals prove compliance, earn trust, and ultimately improve outcomes. The list of Leapfrog members is impressive. Employers include corporations such as Boeing, Chrysler, and FedEx, and organizations of purchasers include various state employers, quality health alliances, and state business groups on health. Patient safety isn't only pushed by hospitals and regulators, it is also supported by nonprofit organizations. One example is the National Quality Forum, or NQF. The NQF helps set the direction for patient safety and quality initiatives in the United States. It does this by defining national priorities and goals for quality improvement, endorsing consensus standards for measuring and reporting performance, promoting these goals through education programs and collaboration across the health system. Who's involved? NQF brings together consumer groups, patient advocates, clinicians, hospitals, payers, accrediting bodies, and research organizations, all working toward safer care. For biomedical equipment technicians and clinical engineers, NQF's standards directly touch your work. Performance measures often track how reliable technologies are maintained and integrated into patient care. Standards may affect reporting requirements tied to medical devices, alarms, and health IT systems. That means every device you service, whether it's an infusion pump or an EHR linked monitor, is part of the hospital's ability to demonstrate the quality and meet these national standards. Organizations like NQF remind us that patient safety is a shared, system wide effort. HTM professionals play a critical role in making sure the technology foundation of healthcare meets those standards. As we said, patient safety isn't just monitored by regulators and hospitals, it's also promoted by consumer organizations that make safety data visible to the public. One example is Consumer Reports. They publish comparative ratings on hospitals, cardiac surgical groups, treatments, and even natural medicines. Their ratings combine both clinical performance data and patient experience surveys. Here's how it works. Performance data. For instance, the Society of Thoracic Surgeons provides outcomes data used to rate cardiac surgeons. Patient ratings. Hospitals are evaluated using HCA-HPS, the Standardized National Survey of Patient Experience. So, where does this come in for HTM? Consumer driven ratings increasingly look at technology reliability and safety. Hospitals can be rated lower if device failures, alarm fatigue, or infection control issues linked to technology are reported, and patient surveys often reflect their interactions with the devices, such as infusion pumps, monitors, even call light systems. Consumer Reports reminds us that patient safety is visible not only to regulators, but also to the public. For HTM professionals, your work keeping devices safe, reliable, and user friendly directly shapes the hospital's reputation and patient trust. Let's talk about the HCAP survey, or the HCAHPS survey, the national tool patients use to rate their hospital experience. The survey asks about things like communication with doctors and nurses, pain control and whether help arrived when it was needed, cleanliness and quietness of rooms, clear explanations about new medications, discharge instructions, whether they'd recommend the hospital, and their overall rating of care. And this matters because patient feedback helps others make smart choices about where to seek care. But it also drives hospitals to improve, not just in clinical practice, but in safety, reliability, and overall patient experience. Patients don't rate the HTM department directly, but their experience is shaped by your work. A pain pump that runs safely, a call light that works every time, monitors that don't generate false alarms, clean, safe devices that reduce infection risk. Every time patients complete that survey, they're indirectly rating the technology you support. Your work behind the scenes directly influences how patients perceive their care. This lecture highlighted how patient safety is strengthened when we combine technology improvements with better workflows, trained staff, and stronger systems. Here are the key takeaways. Patient safety is always a socio-technical process. Technology works best when supported by people and processes. Agencies like the Joint Commission set national standards to tackle issues such as surgical site infections, CRBSIs, and unsafe abbreviations. Infection control in hospitals remains critical, with strategies like hand hygiene, staff immunization, isolation, and safer delivery systems. External promoters like Leapfrog, the National Quality Forum, and Consumer Reports shape safety culture through standards, data, and transparency. And finally, the patient voice through HCAPS, which reminds us that experience and trust are part of safety too. Your work in infection prevention, device reliability, and safety systems directly supports all of these efforts. Patient safety is everyone's responsibility, and for BMETs and clinical engineers, Your behind the scenes work is what makes national goals, hospital standards, and patient expectations possible in real world care.